Good afternoon to all of you. So why do we need to change the depth of the molecular biology of head and neck cancers? Because with changing time, there are a lot of advancement in surgical techniques, new radiation techniques, and new chemotherapy drugs. But with all these techniques, we are able to have a good organ preservation in head and neck cancers. Despite with there is no advancement in survival of these head and neck cancer patients. So we should go in the depth of molecular biology of these cancers so that we can research some new drugs for better control and overall survival in head and neck cancers. Just brief, there are a lot of pathological variety in head and neck cancers like squamous cell carcinomas, adenocarcinomas, adenocystic carcinomas, melanomas. But the squamous cell carcinoma is the most common, and it is around 80 to 90% of all cancers in head and neck cancers are of this variety. The clinical behavior varies from site to site and depends upon metastatic rate and the response to therapy. The risk factors, as has been dictated earlier by all the speakers, the tobacco is the most common factor implicated in head and neck cancers, followed by alcohol use, followed by betel quid chewing and BD smoking in Southeast Asia most commonly. Family history of head and neck cancers, actinic radiations mainly involved in lip carcinomas, and oncogenic variant of human papillomavirus recently studied very much in head and neck cancers. So around 60% of patients after getting a treatment for head and neck cancers, they develop local recurrence or metastasis within 2 years. And the standard of care of these cancers is surgery, radiation, and platinum-based chemotherapy. But as I stated earlier, improvement in surgery and chemoradiation offer better organ preservation, but they have not resulted in only modest improvement in 5-year survival of these cancers. The 5-year survival rates for patients with locally advanced or metastatic disease are only 48 to 26% respectively. So we need a better understanding of head and neck cancers at the cellular and molecular levels to guide development and use of new therapeutic interventions. So the development of cancer from a normal mucosa to invasive carcinoma takes multiple steps, and multiple genes and chromosomes are altered for this process. So it's a multi-step procedure, and it involves the sequential activation of oncogenes and inactivation of tumor suppressor genes in a clonal population of cells. In the early stage of carcinogenesis, there are increased cellular proliferations, a reduction of apoptosis leading to overall proliferation of the cells. Angiogenesis, without angiogenesis, the tumor cannot grow beyond 3 mm. So you need a neovascularization for the tumor to grow or for metastasis. Local invasion and the lymphangiogenesis leading to distant metastasis. These malignant cellular biological properties are dictated by specific genes, its activation or inactivation. So what are the activations procedures which lead to activation of gene function? This is overexpression of a gene, or amplification of a gene, or a translocation of a gene leading to activation of a particular gene. Or it is a downregulation or inactivation of some gene function. It can be due to mutation, deletion of gene, or hypermethylation of a gene promoter, an epigenetic mechanism. So what are the main protocogenes involved in head and neck squamous cell carcinomas? 11q13 amplification leads to overexpression of cyclin D1, a main oncogene in head and neck cancers. Amplification of 3q, p53 amplifications, EGFR overexpressions, and a variant of EGFR is variant 3, and a protein eukaryotic initiation factor involved in signal transductions pathways. And what are the tumor suppression genes involved in head and neck squamous cell carcinomas? It is P16. It is one of the most early event in head and neck cancers. Inactivation of P53 is a late event involved in many of the head and neck cancers, around 50% of the head and neck cancers. 9p21 deletions, 3p21 deletions, p10 mutations and deletions, 13q involving the retinoblastoma gene deletions, and 18q loss of heterozygosity. So this is a picture showing benign squamous hyperplasia leading to dysplasia, then carcinoma in situ high-grade dysplasias, then invasive carcinomas. So I have seen the sequence, but the sequence is not important. It is the accumulation of genetic changes which leads to development of invasive carcinomas. But the earliest event as seen is 9p21 deletion or loss of heterozygosity. Some other are p16 or p14 inactivations, EGFR overexpressions, or telomerase activation. The next step is 3p deletions or p53 mutations, and then again 11q amplifications leading to cyclin D1 overexpressions, 8p deletions, and in the end it comes around p10 mutations, 18q deletions. So the main three genes which are very extensively studied in head and neck cancers are 11q, 13 amplifications, has been seen in around 30% of patients and leads to cyclin D proto-oncogene overexpressions, and this leads to cell cycle progression. Another is 9p21 deletions seen in around 70% of patients, and the main gene which is affected is p16, and it is the one which inhibits cyclin dependent kinases, and because of this the cell cycle goes into progression. Another is 17p13 deletions, and the main gene at this locus is around p53 and seen in around 50% of patients, and inactivation of p53 leads to cell cycle progression or evasion of apoptosis. Others are EGFR overexpressions, and there are multiple genetic locus studied in head and neck cancers. So if you see few, the loss of chromosomal region 9p21 is found in 70 to 80% of cases and represents the most common genetic alteration seen in squamous dysplasia and head and neck cancers. The loss of heterozygosity of 9p21 appears to be an early event in the squamous neoplasia and has found to be in pre-neoplastic lesions, including 30% cases of squamous hyperplasia. The p16 is often inactivated through a homozygous deletion by promoter methylation and epigenetic changes, or less commonly by point mutations. So the CDK cyclin dependent kinase N2A gene locus is found at this chromosomal locus 9p21. It encodes two different transcripts, p16 and p14, which are responsible for G1 cycle regulations and MDM2 mediated degradation of p53. So once p16 or p14 are inactivated, the cell cycle goes to progression and uncontrolled cell growth takes place. The loss of heterozygosity as 17p and the point mutation of p53 are seen in around 50% of head and neck cases, and amplification of 11q leading to overexpression of cyclin D1 is seen around 30 to 60% of patients, and it has been associated with increased rate of lymph node metastasis, one of the most poor prognostic factor in head and neck cancers, and overall poor prognosis. So cyclin D1 induces phosphorylation of retinoblastoma, which is a tumor suppressor gene, thus enabling progression from G1 to S phase. So the both amplification of cyclin D1 and inactivation of P16, both are seen very early events in head and neck cancers, results in increased phosphorylation of retinoblastoma, a tumor suppressor gene, which leads to progression of cell cycle from G1 to S and uncontrolled growth. So now, what are the clinical implications of these genomics in head and neck cancers? The comprehensive analysis of gene expression pattern of individual tumors can now achieved with DNA microarrays. So by using this approach, various clinical needs in head and neck cancers can be addressed, including discovery of biomarkers. What are the biomarkers? Are the biologic molecules which can be detected in pre-malignant or malignant lesions, so that we can study their progression to the invasive carcinomas. They can be used in progression of pre-malignant lesions, disease is present or not, prediction of clinical outcome or the prognosis, or identification of target for therapy, mean the clinical implications. So the progression of a pre-malignant lesion, the biomarkers for this are chromosomal polysomy, suprabasal p53 expression, loss of heterozygosity as 9p3p, and one of the most significant predictors for invasive carcinoma development. Patients with progression to in situ or invasive carcinomas showed additional losses on 4q, 8p, 11q or 17p. So by seeing these biomarkers in the tissue, you can say that there's a premalignant lesions going to be developed into invasive carcinomas. And a DNA content appears to be an independent prognostic factor, which with no statistically significant correlation with the grade of dysplasia. Now it can also help in detection of minimal disease in the surgical margins. When you do the surgery and we say the histological margin negative, but when we study at a molecular level, around 16 to 20% of these negative margins may be molecularly positive margins leading to recurrence of the disease. So detection of genotypically abnormal cells at the surgical margin of resection may be helpful in identifying the patients with a high risk of local recurrence after complete surgical histologically negative margins. So the prognostic value of overexpression of proto-oncogene is a eukaryotic initiation factor 4E in a histologically negative margins has been found. And this factor is mainly involved increase in almost all head and neck squamous cell carcinomas cases, and this has been detected by using IHC techniques, and Nathan et al. Showed statistically significant difference in local recurrence rate and disease-free survival intervals between this factor positive and this factor negativity at the margins. So the patients with this factor's positivity at the margins have around 6.5-fold risk of doubling local recurrence. This factor was reported to be a more sensitive prognostic indicator of local recurrence than P53 by IHC. Thirdly, as we classify the breast cancer at molecular levels, similarly we can have a molecular classification of head and neck squamous cell carcinomas for recurrence and survival prediction. So data was formed from molecular classification suggests that the recurrence, at least in part, is an intrinsic biological property of the primary tumor, and this recurrence signature can be detected before initiation of therapy. The recurrent disease signature involves overexpression of genes which are implicated in stromal invasion, RAS signaling, cell surfaces, extracellular matrix interactions, or angiogenesis.
Just got 2 minutes to finish.
And the metastatic signatures like collagen 11 and tissue inhibitor of metalloproteinase. Then we can use this genomics to detection of metastasis. We can predict which tumors are more likely to have a lymph node metastasis or distant metastasis by showing the gene expression analysis through for various subsites. The subsite analysis will incorporate anatomic difference of each site, which may result from different lymphatic drainage, etiology, or genetic differences. The unique feature of head and neck cancer is field cancerization that allows independent transformation of epithelial cells at number of sites. The second, metachronous synchronous tumors of aerodesitraca are very common. Around 10 to 14% have second primary cancer in head and neck sites. The patient with primary lesion often have skip areas that are characterized by pre-invasive lesion throughout the field, and these lesions shows the similar molecular findings as compared to the primary lesion. So the histologically benign mucosa may harbor molecular pre-neoplastic cells, and which are genetically related to metastatic squamous cell carcinomas. Now the third most important target for therapy. Some of the target for therapy in head and neck squamous cell carcinomas are epidermal growth factor receptor. It is a tyrosine kinase receptor, and it mainly binds to epidermal growth factor and transforming growth factor alpha. The ligand binding results in receptor dimerization, then activation of intrinsic kinase activity, and leading to phosphorylation of tyrosine residues within the cytoplasmic tail, then leading to a signal transfer pathway, leading to numerous mitotic signals, leading to cell growth, proliferation, differentiation, or migration. So this is the structure of a EGFR receptor. Once the ligand binds to the receptor, there is a dimerization leading to signal transduction pathway. There are the 4 receptors, mainly ERB1, 2, 3, and 4. ERB1 is called epidermal growth factor receptor, and ERB2 is called HER, mainly in breast cancers. So the overexpression of EGFR is seen in around 40 to 80% of head and neck cancers, and 7 out of 8 trials have showed a poor outcome with this overexpression of EGFR, and is strongly related with poor prognosis and resistant to chemotherapy or radiotherapy. This is the mitotic signals induced by binding of ligand to this receptor. There are mainly RS, MAF, kinase pathway, PI3K pathways, STAT3 and phospholipase C pathways. So, what are the reasons to block this EGFR?
Excuse me, time is up. Actually, there's some
Just
message you
1
want to
second.
communicate. Please do
1
it
minute.
fast, right?
Yes. These are implicated in cell proliferation, metastasis or resistant ovarian therapy. So this receptor should be blocked. Thank you, sir.